Thank you, Daniel, Fosfandre, and Gaston. It's such a pleasure, Sergio, to be back with you, the same team from ICSES. And these are such fascinating lectures. The topics you've selected are eclectic, so I just cannot leave my screen. I'm totally focused on this. So continuing with this theme, let me pursue with the topic on Arthrolatarjet and our experience. And we are aware that the Latarjet has undergone so much evolution from the original accidental Latarjet that it was from the failed Elmsley Tria that Michel Latarjet did, to the extent where Laurent Lafort converted. And I think that was a complete inflection point to introduce arthroscopic Latarjet. And you must understand where I came from, that I was a dedicated open Latarjet surgeon and I was a complete naysayer against Arthrolatarjet, till such time that I visited Annecy, and it took one day in Laurent Lafort's theater where he did 5 Arthrolatarjets to convert me completely. So having come from there, we all agreed that after that excellent talk by Giovanni to explain that there is a lot of difference between Latarjets that are done between all of us, depending on how we split the subcap, how we deal with the capsule, do we release it, do we repair it, do we burn it, and also where we put the graft, whether it's a standing graft or a Bristow type graft. So I don't think all the Latarjets between all of us are the same. So because of the variations that we do between ourselves. So on the Arthrolatarjet, I do accept that there's a steep learning curve, and I still have some very close international friends who have sworn they would never, ever do an arthroscopic Latarjet. And that kind of freaked me out in my initial days that, oh, this is something that should never be done. There are risks. It is not really an arthroscopic procedure because it is mostly a soft tissue endoscopy. And that's why we must understand that the field can be full of blood and you can get stuck and you should be able to bail out quickly. You are flirting very close to the nerves, especially the musculocutaneous and axillary nerve. There have been contentions, issues about the arthroscopic Latarjet, about the fact that one doesn't deal with the capsule, then the graft is not extra-articular, and one doesn't address the IGHL or in fact burn down the capsule. But it still remains a very elegant and a most precise technique to fix in the graft in the most accurate manner ever compared to all the other techniques as such. So the reason I'm so fascinated, I think it's a procedure that requires relentless pursuit of perfection, and you have to approach with great tenacity because it requires patience. My first arthroscopic Latarjets in 2013 used to take almost 3.5, 4 hours, and we've come down over the last so many years that now an average time this year has been about between 1 hour 15 minutes to 1 hour 30 minutes. So it's a matter of practice, it's a matter of understanding, and once you reconcile that this is a procedure that requires a little gumption and you're ready to give it, then you will achieve this. Sometimes you're faced with an epileptic patient such as this 25-year-old gentleman who's a chronic seizures patient with an excess of 30% bone loss. I'm not going to use the coracoid because of 2 different reasons. The graft can get avulsed, so we prefer the ICBG in these patients, and the fact that I have a much larger graft that I can bespoke design for fitting in a 30% defect. I use the same technique as the Arthrolatarjet, but I fix the screws to the iliac crest as you see on the top there first, and then resect the iliac crest to get a tricortical graft of about 25 mm width. It is important to find the axillary nerve, dissect it under vision, and at the same time give the same respect to the musculocutaneous nerve in every Arthrolatarjet case as possible. And then this is the final, you can see how well the graft is so flush as if it is designed. And I remember Joe DeBeer's words that God designed the coracoid to fit for the Latarjet. So as if it was tailor-made for the Latarjet. And you suddenly, when you start fixing the graft in a congruent arc manner, you will agree that it absolutely fits the curvature as if it was designed. And I'm very much here on the same page as Jeff Abrams, that the capsule and the labrum are proprioceptive organs and you need to repair them. So 3 years down our experience, I started to save the capsule and the labrum. And now, as far as possible, I would do a capsular labrum closure after the Latarjet. It adds another 10 minutes to the procedure, but I think it makes a lot of sense. So if the capsule is viable and labrum is viable, I actually resect the labrum on the top end, keep it connected to the 6 o'clock position, and park it in the posterior portal with a suture inside it. So a PDA suture that goes inside it will keep it parked. At the end of my Latarjet, as you see that the graft is down here, I will go and pick up the labrum, hold it vertically stretched, and pin it back with a couple of anchors and then give them. So number one, it renders the graft extra-articular, so saves the humeral cartilage, provides a proprioceptive organ there, and makes it as anatomical as can be. So of course, in cases where there is no labrum and it's poor quality tissue, I'd go ahead and just debride it and the Latarjet would still work. I would always do a post-op CT scan for all my patients between about 3 to 6 months post-operatively, because the X-rays do not give us enough information. So important to understand that graft is actually healed. It is not mandatory that it will heal, and the position of the screws and the alignment of the graft, whether it is flush or recessed. So as Giovanni referred, osteolysis and Latarjet are inseparably associated with each other. And especially for surgeons who do Latarjets for all their instabilities where there is minimal glenoid bone loss, feel free to expect extensive osteolysis. This is Philip Morodo's paper, and there's another paper by Young-Algree in the cases TA. You can see that there's extensive graft osteolysis. It can have clinical unsatisfactory results and up to 22% failure rates. And of course, that naked metalwork that is there can damage the cartilage of the humeral head as well. So the only two indications that I would use a Latarjet for in the absence of glenoid bone loss would be one case like this where there's a complete haggle and there's no capsule there for repair. This is a patient who was dislocated 20-25 times and came in very late, and there's nothing there to repair. I would do the Latarjet. And perhaps the patient who's a failed Bankart with very poor quality capsular labral tissue, I might consider doing a Latarjet. But that really is a complete exception. A good paper from the French Arthroscopic Society, massive number of patients, 1555, very minimal complication rate with the Arthrolatarjet. But a word of caution here, these surgeons are volume surgeons who have done extensive arthroscopic Latarjet with amazing experience. So I don't think we should compare them with all the other conventional surgeons as such. In our study, which has just been submitted recently, where we studied all our grafts and we have 200 patients in the study, we found out that 85% of our grafts are in the lower sector and about 12% in the middle sector. Only a couple of them came in the earlier stages in the high sector. We also studied our alpha angles of the screw insertion, and we're pleased to say that 93% of our grafts were flush, about 4% were proud, and 3% were recessed. With considering that the average lateralization was just 3.3 mm with our Arthrolatarjet. Of course, our later patients in the recent experience have been far better. We also compared our first 25 to our second 25 and found out there was an incredible improvement between the parallel screws, the lack of skew screws, and only one patient had screws that were out in our second half of our study. So we think that at least 50 Arthrolatarjets is your learning curve, after which we start flattening the curve as such. Why would one do a CT scan post-op? For several reasons. Number one, 6 to 10% of the revisions are due to screw problems, and there can be several on there. If the graft is a fibrous union or a non-union, the screws are inevitably going to break, and the X-rays do not give you the full picture. Erroneous placements have problems. Most common reason for me to remove the screws is suprascapular neuropathy that gets unrecognized. If I have screws in the upper sector going upwards towards the superior spinoglenoid notch, I would definitely remove those screws within 3 to 6 months, provided the graft has healed completely. And of course, to note down osteolysis, which the X-rays do not show you adequately. I think Giovanni has a huge lifetime work on osteolysis and Latarjet here. Now, these are some of our problem patients. And this is a 53-year-old doctor, chronic depression, on meds for depression. He's 120 kg weight, fell in the bathroom on the 9th day post-op. And then we said, it's okay, we don't need to do. We did his x-rays and looked excellent. Started his rehab after 2 months and was doing well. But as I said, the x-rays don't show you enough. Houston, we have a problem. So although the first 2 CT scans show okay, on the second one, you see the graph has completely avulsed off. He's clinically doing well, but this, unless we did a CT scan, would never, ever notice what is happening here. This is a young 21-year-old wrestler whose graft never healed, and he continued wrestling. And then 7 months down the line, his screw started breaking. We had to do an Eden hibernate for him to revise him as such. So you can see that the CT scan shows you a far better picture, and the reality than the X-ray can reveal half the truth. And then occasionally I do a premature coracoid cut, and then I have a very small 18 mm coracoid. I would use only one single screw. Will go slow on these patients. He was a revision Latarjet from a failed Bankard, but fortunately his bone graft has healed, and that was well established only on the CT scan and not on the X-ray. So in conclusion, I think coming to our end, there are several other issues about the assessment of glenoid bone loss. If we have imperfect information, I don't think we can take perfect judgment. Restriction of external notation was noticed in our series when the grafts were higher positioned. And then there's a complication rate with nerve injuries. I think Inho John's paper here from 1999 and several others have shown that you need to be careful about the nerves. On the revision Latarjet, I'm not so worried. Post-arthroscopy, we see a much lesser scarring. And if my patient has fallen, injured, and broken the graft, I'm okay with that. My biggest worry is the grafts that have healed and then they have failed. And those are the laxity ones, and those are the nightmare ones. So lastly, in conclusion, I think the long-term failure of Latarjet can be a very challenging problem. I don't think Latarjet is a solution for all difficult instabilities. Unless there's bone loss, we should not attempt the Latarjet. And there's a lot of discussion between whether the ICBG is better, or the Latarjet is better, or the tibial allograft is better, but that's for another day's discussion. But osteolysis, as I said, is inseparable from Latarjet if you do it in the absence of glenoid bone loss. Thank you very much for your kind attention.